All right. Can you see my screen?
Yes.
All right. Okay, so again, my name is Allison Sela. I'm the medical director for intensive care and cardiopulmonary services, including pulmonary rehab at Preston Memorial Hospital, which is part of the Mon Health system in Kingwood. And today we are going to talk about COVID-19 and the lungs. So our objectives for today are to discuss the symptoms of COVID-19 and how they affect the lungs, to discuss treatment of pulmonary COVID-19, and to discuss post-COVID pulmonary disease. So COVID-19, also known as the SARS-CoV-2, it's a novel coronavirus, which means a new strain of the coronavirus, which has been around for forever. Asymptomatic infections can occur in about 33% of patients. And the spectrum of disease with COVID ranges from mild to critically ill. Approximately 81% of our patients will have mild disease, 14% will have severe disease, which would require hospitalization and possibly even ICU care. And then about 5% require treatment for critical disease, which generally ends up needing some sort of advanced support, such as a ventilator. 20% of patients require hospitalization, and of those, 25% require ICU care. And anywhere, wide variety of 30 to 100% of critically ill require mechanical ventilation. The picture shows a temporary COVID unit set up in a hospital here in the United States, where they're caring for these patients all in the same area. And you can see the healthcare providers dressed from head to toe in personal protective equipment. So some of the risk factors, although we know that this particular virus does not follow any of the known patterns, of some of our other viruses, but some of our risk factors include advanced age, comorbidities, specifically cardiovascular disease, diabetes, lung disease, cancer, chronic kidney disease, obesity, smoking, socioeconomic status and sex. Males are more likely, and patients of Black, Hispanic, or South Asian descent are more likely to get COVID. And then there are certain lab abnormalities that made patients more prone to getting COVID. Clinical manifestations. COVID has a long incubation period, up to 14 days, and that goes into why these patients, or why we quarantine for 14 days after an exposure. Most common symptoms are cough, myalgias, and headache, like any other virus. The most frequent serious symptom is pneumonia. And usually with these patients that have pneumonia, we see a fever, cough, shortness of breath, and bilateral infiltrates. There are no specific signs or symptoms that are characteristic of COVID-19. I know oftentimes you'll hear people say that they lost their sense of taste and their sense of smell, but if you think back to that last severe cold that you may have had, I bet you couldn't smell or couldn't taste during that either. So even that is not specific for COVID. Symptoms of COVID-19 are listed here. About 50% of patients will suffer with a cough. There is a fever, whether it's either subjective, patients say that they feel warm, or whether a true fever in about 43% of patients. Now this, I think, has changed somewhat with the Delta variant, but that information is not too much off from this, I believe. Myalgia in about 36%, headache 34%, then it goes down in dyspnea, sore throat, diarrhea, nausea, vomiting, and then about 10% each experience loss of smell or taste, abdominal pain, and rhinorrhea. So complications related to the coronavirus include cardiac and cardiovascular complications, including arrhythmias, myocardial injury, heart failure, and shock. These patients can also develop thromboembolic complications, including DVT and pulmonary embolism, as well as neurologic complications. Approximately a third of patients hospitalized with COVID will develop encephalopathy, some confusion. We can also see shock, some types of movement disorders, motor and sensory deficits, ataxia, and seizures. There are some inflammatory complications, persistent fevers, elevated inflammatory markers such as D-dimer and ferritin, elevated pro-inflammatory cytokines. We see Guillain-Barré as a complication. And then we also see multi-system inflammatory syndrome. This is rare in adults. Mostly we see this in kids, but when patients develop this multi-inflammatory syndrome, there's actually minimal pulmonary complications that go along with that. And then secondary infections can also be seen. This is a rare complication, but patients can develop either bacterial or fungal infections. So respiratory failure is associated with coronavirus, and the most common complication that we see is ARDS, or acute respiratory distress syndrome. These patients, usually their symptoms will progress over the first week of illness. And in one study of patients that were hospitalized for COVID pneumonia, approximately 20% developed ARDS. Another number I saw showed that in the United States, 12 to 24% of hospitalized patients required mechanical ventilation. And I believe that was the number that was quoted in the other study that I had on my earlier slide, that about 20% of hospitalized patients require mechanical ventilation. So this slide shows some imaging studies from patients with COVID. Early in the disease, chest x-rays and CT scans may look completely normal. And in fact, 20% of patients may not have any chest imaging abnormalities at any point of their illness. But those that do, we can see several different findings. We can see some type of consolidation or ground glass opacities are the most common. And these can be either in both sides of the lungs, they can be on the outside of the lung, they can be in the lower part of the lung. Again, there's not a hard and fast rule that coronavirus is following. And so you can see, can you see my arrow?
Yes.
Okay, so there is an infiltrate here, there's an infiltrate over here. This one has a little bit of a patchy ground glass infiltrates on the outside and over here. This one is more throughout, evenly distributed. It looks like it actually spares the lower lobes of the lungs. This one, again, is pretty diffuse, all of this white fluffiness. Same with this one, but it looks like maybe some specific consolidations located throughout. This one appeared to spare the upper lobes and affected mostly the lower lobes. This one sort of hazy throughout, but more so in the lower lobes. This one, again, hazy throughout, and this looks like a pretty normal chest x-ray. So you can see that there's not any hard and fast rule that coronavirus is following. So CT imaging, again, there may be some findings that are characteristic, but nothing that is if I look at the CT scan, can I say, oh, absolutely 100% this patient has COVID, we don't even need to test them. So the Radiological Society of North America recommended that we characterize CT scans for these patients as either typical, indeterminate, or atypical for COVID-19. And so what the most common finding, again, is ground glass opacifications with or without consolidation. So approximately 83% of patients had ground glass opacifications, and 58% had a mixed consolidation picture with those ground glass opacifications. 52% had some adjacent pleural thickening, which we saw on, let's see, this x-ray right here looks like possibly there's some pleural thickening. You can sort of see how the pleura is a little bit darker, brighter. And then 48% had some intralobular septal thickening, which is the area between the lobules of the lung gets a little bit thick and can sort of show up and be a little bit more it shows up sort of white, and it almost looks like, the best way I can describe it would be sort of like what the spots on a giraffe look like, where it's a very sort of like reticulated appearance, I guess is the best way to describe that without putting a picture in here. And then air bronchograms are seen in about 46% of patients. And the air bronchograms generally go along with consolidation of the lung. That's a typical finding that we see in patients that have pneumonia. They generally tend to have air bronchograms as well.
Dr. Sela, do you mind if I interrupt you for a moment?
Sure.
Dr. Doyle has his hand raised, so I was just seeing if we could get to him. Maybe it was something pertaining to that slide.
Sure, Dr. Doyle.
Allison, we hear ground glass opacification as a radiologist term, but I'm sometimes uncertain what that actually means. And since you're explaining, and Carl, you might want to comment on this, but could you give us common language description for what ground glass opacification means versus just regular consolidation or infiltrate?
So, so ground glass is a description of a type of glassware where they took the glass and they sort of sanded it down, and it has this opaque white appearance to it. And that is the descriptive term because that's what it looks like in the lungs. You've got this opaque white appearance to a portion of the lung. So it looks like you're looking at a piece of ground glass. Normally the lungs should appear black. Air appears black on CT scan and chest x-ray. And so when you see like this white opacification, less, I would say that it's generally, it appears less solid than what we would call a consolidation.
Thank you.
Uh-huh. And this is a good picture of those ground glass opacifications. And that's what this area right here looks like. This here, you can see that here as well. These areas are all considered ground glass opacifications. Another method that we used early on during COVID was lung ultrasound. And this was because, you know, we didn't know a whole lot about how to contain the spread the best way possible and not contaminate other areas and other people in the hospital. And so lung ultrasound is a portable modality, you know, that can be done right at the patient's bedside without having to push them through the hospital and potentially expose other people. And so what we saw on lung ultrasound, or what we see on lung ultrasound, is that there is a thickening or a discontinuation or an interruption of the pleural line. Normally the pleural, you know, the pleura is the lining of the lung. So normally it's a very solid, continuous surface. But we're seeing that it is not so smooth, not so connected. There are some interruptions in it in patients with COVID-19. We can see other types of consolidation, some air bronchograms. This, let me see if I can get this to work here, is a lung ultrasound. So A shows normal aeration and normal lung sliding. So lung sliding is when the lung moves and it slides against the pleura, and that's a normal thing that you want to see. The lung should be able to move freely against the pleura. And that's what we can see here. And we can see some A lines, which are these somewhat horizontal lines moving through. Down in B, we see reduced aeration. You can see that it's a little bit darker. We can see reduced lung sliding, so it's not moving quite as freely. You can see that right sort of at this line here. And then we can see some B lines, which are these vertical lines that are appearing white on this ultrasound picture. Excuse me. In C, we can see that there is even less movement of the lung against the pleura. There's less aeration. And then we can see some B lines. That's what these lines are going here. And then in D, you've got almost complete collapse of the lung. Excuse me. You can see some vascular markings, which are what these white things are here. And you can see some air bronchograms, which is what this black area is here, is that there is, what it is that the lung tissue is consolidated around the airway, but the airway is still open. And so that's what this black shows, is that this airway is open, but this lung all around it is consolidated, not moving, not functioning like it should. And so if you can compare D up here to A, and you can see this is normal, and this is what we're seeing, you know, any of these stages is what we're seeing in patients with COVID-19. Now let me figure out how to get back to my PowerPoint. All right. So next I want to move on and talk a little bit about the management of acute pulmonary disease for these patients. So what we found when we went back and looked at the development of symptoms and how these patients progressed is that patients that develop critical respiratory disease generally have a late onset of shortness of breath, usually about 6.5 days after their other symptoms may start. But once they develop those respiratory symptoms, they progress rapidly over the next 2.5 days. Usually what we're seeing is hypoxemic respiratory failure. Hypercapnia is rare. And then these patients are generally requiring ventilation for at least 1 to 2 weeks. This says they fail early intubation. It should be they fail early extubation. So usually what happens is if we try for extubation within the first week or two, they generally fail and have to be re-intubated. However, they are most of them do not need a tracheostomy. So if they're able to come off of the ventilator, they are able to successfully wean later on. But patients whose lung disease never gets any better generally do not make it to the stage where they need a tracheostomy. So patients usually go in one of two camps. Either if they're intubated, they get better and they're able to come off successfully, or they get intubated and they never improve, unfortunately. So we want to avoid nebulizers in these patients in order to prevent nebulized spread of disease. And so the better thing to do is to use MDIs for our inhaled medications. And this is, you can see that there is a holding chamber here. You can see the MDI hooked up here. And so we're able to give patients these breathing machine, MDI treatments, nebulized, as opposed to nebulized treatments right through the mechanical ventilation. And this hooks up to the patient's ET tube. If nebulizers are required, they should be given in an airborne isolation room. These patients do develop hypoxia. Our goal saturation for these patients is 90 to 96%. They can use a regular nasal cannula up to 6 liters per minute, and then a non-rebreather up to 10 liters per minute. High flow nasal cannula and non-invasive positive pressure ventilation was controversial early in the start of this because there was a risk for aerosolization. And so, these patients needed to be in isolation. There was a recommended use of surgical mask over high flow or non-invasive ventilation. High flow generally preferred, except for in hypercapnia. And then these patients needed reassessed frequently. Unfortunately, with the state of things now, we don't have much other options. Our ventilators are being used, and we are having to use these other non-invasive modalities to treat patients. So indications for mechanical ventilation for a COVID patient, same as they always are. There's nothing that's specific to COVID. So signs of respiratory distress, such as using their accessory muscles or paradoxical abdominal breathing, rapid progression of disease, saturations that remain less than 90% despite maximal supplemental oxygen, an arterial pH of less than 7.3 with a PaCO2 of greater than 50, patients requiring more than 40 liters per minute of high flow nasal cannula with an FiO2 of greater than 60%, and hemodynamic instability or multi-organ failure. All of these would be an indication that the patient has progressed and would need mechanical ventilation. ARDS management is the same as it always has been, nothing specific to COVID. We want to use low tidal volume ventilation, 6 milliliters per kilogram of predicted body weight, respiratory rate of 25 to 30 to start, with a goal of 10 to 15 breaths per minute. PEEP FiO2 ratio, you want to keep your PEEP somewhere between 10 to 15 centimeters of water to start, and then titrate your oxygen PaO2 to 55 to 80, or your oxygen saturation is 90 to 96% for most patients. You want to try and keep your plateau pressure of less than 30 centimeters of water, and with your goal pH being something that's greater than 7.15. Remember, permissive hypercapnia is allowed with ARDS. One of the things that we found to be beneficial is prone ventilation. And so we flip patients onto their stomach, which allows the dependent portions of their lung, which generally, if you're laying in bed, is the back of your lung, to become aerated. So by keeping them on their stomach, we're allowing that those areas of the lung that generally get better perfusion, so better blood supply, can now get better oxygenation as well. And so the advice is to keep patients in this position for somewhere between 12 to 16 hours per day. And so as you can see here, patients have they have IV lines, they've got ET tubes, they've got nasogastric tubes, they've got blood pressure cuffs, they've got ART lines, they've got Foley catheters. There's tons of lines and things going on. And so you need to have staff that can do this. We have to make sure that when we flip somebody over, because it takes a lot of work, that their ET tube doesn't come out, because then we have to flip them right back over and fix the ET tube. And make sure their IVs don't come out. And once we put patients in this prone position, we usually start to see the effects somewhere between 4 to 8 hours after we flip them over. The longer you use it, the longer we see these improvements. And then, flip them back over to rest for a while, and then go back at it again the next day. Other rescue therapies that are used for these patients, recruitment maneuvers and high PEEP strategies in order to try and recruit portions of the lungs that may not be used. This is especially used in those facilities that maybe can't prone patients, or if the patient couldn't tolerate the prone positioning. Trials of inhaled pulmonary vasodilators, such as nitric oxide or epoprostenol. Neuromuscular blockade for patients with refractory hypoxemia. So if their PDAF ratio remains below 100, or they have ventilator dysynchrony, we tend to mobilize these patients, which really takes away their ability to fight the ventilator and allows the ventilator to do all of the work of breathing for them. And then as a last resort, Ecmo, and this is an Ecmo machine seen in this picture here. What you do is you take the blood out of the patient, you run it through the Ecmo machine, which oxygenates the blood and gives it back to the patient in hopes of helping with their oxygenation. And that is currently being offered at WVU for select patients. Post-Coven pulmonary complications. And this is what I'm seeing in my clinic. So I don't know if there's a way. I've got like a black box at the top of my screen, which blocks some of the slide. I apologize for that. But this slide shows, so week 2 and week 1 prior to symptom onset. So this is when you're exposed to COVID. And then you start developing symptoms at this dotted line here. This purple arch shows when we're able to isolate the virus from the respiratory tract, and that goes for about the first 10 days. The nasopharyngeal tract isolation lasts a lot longer and can last, even into months down the road. And so some of the things that we can see from these patients, is some fatigue, some decline in the quality of life, some ongoing muscle or joint pain. They end up with dyspnea, cough, a persistent oxygen requirement, anxiety, depression, sleep disturbances, post-traumatic stress disorder, cognitive disturbances or brain fog, headaches, palpitations, chest pain, chronic kidney disease, hair loss. And so these things can persist, for 3 to 6 months out, even longer in some patients. And this slide shows ongoing complications and side effects post-COVID. And at least 80% of patients admit to having one symptom or more. And you can see that fatigue is the most common, coming in at 58%. Headache, which is what, I don't know if you guys can see that or not. I have a whole bar up here, but headache is the next common. So not only are they listed in these bubbles here, but they're also listed in this this bar graph down at the bottom. Attention disorder, hair loss, dyspnea, those are probably going to be the most common that we see, but you can tell that this affects the entire body. There's not one organ system or anything that can be spared with COVID, which is why it's been so debilitating for our patients. So, you know, early on, and even a little bit now, there's not a whole lot known as to how these patients are going to do a year, 2 years, 3 years down the line. But we've been able to make generalizations from other SARS viruses. And so we know that a lot of patients can have significant impairment in their pulmonary function for the first few months after recovery. Radiologic changes may not correlate to clinical symptoms. And so we see it going both ways. We see some patients that have pretty significant changes on their chest x-ray or CT scan that aren't quite so symptomatic. And then we see other patients whose chest x-rays look almost back to normal, but are still struggling, needing oxygen, or extremely short of breath, or limited in their day-to-day activity. Some imaging changes may last for a long time, and a lot of these imaging changes look like any other typical viral pneumonia on chest x-ray. And so what we can see with that is diffuse alveolar damage. We can see interstitial lymphocyte infiltration, edema, fibrosis, alveolar hemorrhage. And so you can see here that this patient has all of this white area that sort of looks like a cotton candy or like a webbing in their lungs is abnormal. And this is some fibrosis of the lungs, so scarring and stiffening of the lungs so that they're not able to get air in as effectively. They're not able to exchange oxygen for carbon dioxide as effectively. And then they generally end up being very short of breath, very limited and debilitated on what they can do, with a lot of patients requiring supplemental oxygen. Again, we can see these ground glass opacities, and then at some point during their disease, these patients may end up with a consolidation on top of these ground glass opacities. In late stage COPD, or I'm sorry, I'm used to COPD. In late stage COVID, these patients will progress to having pure consolidation, and those ground glass opacities will then appear as these consolidations resolve. So we start with ground glass opacities, then you get a consolidation on top of that, then you have only consolidation, and then the consolidation sort of fades back into ground glass opacities. And so here you can see at day 7, we've got some ground glass opacities here with maybe a little bit of consolidation. At 14 days, you can see this is mostly consolidation, and you lose a lot of this hazy ground glass opacities. And at 30 days, you start to see that things are headed back towards the ground glass opacities. This looks more similar to this area up here, with these consolidations sort of fading off. And you can see these band-like scars, which is what this is showing, and this is showing, and this is showing over here. Again, you see ground glass opacities here. You can see here that they become a little bit more solid and consolidated. And then here they start to form these fibrotic bands, which in some patients never resolve. Severity of complications depends on the patient's age, their comorbidities, their smoking status, the length of their hospital stay, the severity of their acute illness, and then what types of medications or treatments they receive. Post-COVID complications, one study identified over 50 long-term effects of COVID-19, and that was the diagram that I showed earlier. This was obtained from 15 studies that looked at over 47,000 patients, and they followed up with these patients from 14 days to 110 days post-infection. They ranged in age from 17 to 87. 80% developed one or more long-term symptoms. Again, we discussed this earlier, fatigue, headache being the most common. About 34% had abnormal chest images. Other pulmonary complications and symptoms that they had included cough, chest discomfort, decreased diffusion capacity, sleep apnea, and pulmonary fibrosis. Another post-COVID study looked at 55 post-COVID patients 3 months after discharge. 35 or 64% had persistent symptoms. 39 or 71% had radiologic abnormalities. Most commonly were interstitial thickening and fibrosis, and approximately 25% of the patients in the study had decreased diffusion capacity. This study looked at 57 patients 30 days after discharge, and they found that 53% had a decreased diffusion capacity and 49% had diminished respiratory muscle strength. And so for follow-up of these patients, it's important that they follow up with a pulmonologist, whether they have a pulmonologist or whether they need to establish with one. We do need to be doing pulmonary function tests on these patients to see if their diffusion capacity is affected, imaging studies for follow-up, and then considering pulmonary rehabilitation for these patients. I've had several COVID patients that have gone through our pulmonary rehab program and have done really well. And then I included my references. And then I wanted to end with this quote from Dr. Fauci, who said, "One thinks about the worst nightmare of an infectious disease person who's interested in global health and outbreaks. It's the combination of a new microbe that has a spectacular degree of morbidity and mortality. And here it is, it's happened. Your worst nightmare, the perfect storm. It's one of those things where you're really just functioning on adrenaline. We're learning on the fly, learning on the job, building the plane as they're flying it." And that's all I have. I'm happy to answer any questions.
Thank you so much, Dr. Sela. That was a wonderful presentation, and I really like that you ended on a quote like that. It's very impactful. Does anybody have any questions or any type of comments?
Dr. Doyle?
That was applause. I always have questions, but I'll wait a few minutes.
If you have a question, you go ahead and ask that, Dr. Doyle. I don't see anybody else coming in yet.
Okay. Two specific questions, Allison. If early on, well, I already got past my ground glass question, and that was really helpful for me, by the way. I was clueless about ground glass. I was trying to imagine kind of broken glass on the floor.
Dr. Doyle, I'm having a hard time hearing you or understanding you. Are you okay, Allison? Can you hear him? Dr. Sealis?
He's cutting in and out.
As usual, without my earphone. How about now?
That's better, yes.
I have to be in the perfect sweet spot in front of this computer at work. I was saying that you already answered my ground glass question. That was really helpful because I've been imagining broken glass on the floor, and your image of grinding a glass, so it's rusty on the side, that really helped. And then your demonstration made it even better. But I have a specific question. Early on, you mentioned an incubation period of 14 days, and since that's kind of the outer limits, could you say what the median or the average, and particularly with Delta variant compared to original or wild type?
Honestly, I'm not sure if it's changed much. I know that generally we're seeing anywhere that symptoms can appear anywhere between 5 to 14 days, but I know that it appears to be more on the side of 5 to 10 days. And that's why the CDC has updated some of their guidance regarding isolation and quarantine and those sorts of things. But it can be as late as 14 days.
Elizabeth and Mithra, you've sat in on tons of COVID-19 echoes. What do you feel like is the latest you're
Dr. Doyle, I still can't hear you. I don't know.
Okay, then I give up. I yield.
Don't give up. You can type it if you want to too. I apologize. I'm having a hard time. Dr. Sela doesn't, so it might be on my end as well.
Typical, you guys have been on lots of COVID-19 echoes. What's the typical these days incubation period for Delta? I mean, I was thinking it was shorter, like typically 3 to 5 days. But I'm not sure either. Anybody hear that?
Some of it.
I heard it. Basically, what he's asking is that, are you hearing anything different on the COVID-19 echo sessions about the incubation period, specifically for the Delta variant?
Dan, turn your video off and we'll be able to hear you better.
Test, test, test.
Much, much better.
Interesting. But Allison got it. That was my question about whether there's a shorter incubation period with Delta and what it is.
I haven't heard it be any different. If anybody else, I haven't heard a difference in that or a discussion yet pertaining to that, but that would be a great question to include into the next COVID session. The last one was really interesting as well, if you guys haven't watched it on YouTube. But to my
anybody else? Okay, I've got one other question, Allison. Can you hear me?
You're cutting in and out, but I can hear you.
Hopeless. Selection criteria for Ecmo. Big ethics question in hospitals. And so we have it at CAMC. I think there's something like 18 Ecmo units in the state. Somewhere between 10 and 20. What can you want to comment on selection criteria? Everybody who needs it isn't going to get it. Everybody who needs a simple physiological criteria isn't going to get it.
I have to admit that that's not something that I'm involved in, and so that's not something that I've kept up on. And I apologize. I should have for this echo topic.
Any other comments?
I'm gonna ask. This is Carl Wernz. I'm actually. This is a question of curiosity. I know that a couple weeks ago our referral system in West Virginia was kind of backed up, and pretty sick people were being continued to be cared for in smaller rural hospitals. Are you still experiencing that in your environment?
Absolutely. Well, for O'Kill and Allison, you're in one, you can comment. And we've got Benedict Payne and Joseph Adornato in the northeast tip of New York State. So it'd be great to hear from people in other rural hospitals.
And we're still seeing these patients in Preston. Fewer and far between because they seem to be getting sicker, but and sicker patients are being transferred out, but we are still seeing some of the less acute patients.
Are you still able to transfer people out, or are they being backed up and you're keeping people sicker than you usually would keep? That's kind of my question.
I have not looked at our inpatient census over the last 3 days, but we had not had anybody that had been sicker than what we usually cared for at this point in time.
Dr. Sela, I
Yes.
think currently we do have a few that need transferred, but their bed holds, and WVU and Mon aren't taking those.
Okay, thanks, Terry.
Thank you so much. Are there any other comments or questions? All right, well, I'll just make that final announcement and put that voluntarily poll up. Please, if there's something on there or suggestions you have for us as a team or any topics, please do let us know. I will go ahead and launch that after this. Our announcement, only one is our next session is October 4th with Lisa Emery. She's going to be discussing matching the inhaler to the patient. So just give me one moment and thank you all.